I was making sure it wasn't the other Julie. Hello, everyone. I have the pleasure of introducing our next speakers. In this session, experts from DC Health and the Department of Forensic Sciences will discuss opioid trends, testing, and composition in the district. This data will provide further perspective and evidence into the opioid epidemic here in DC. Our speakers will include Kenan Zamore of DC Health and Dr. Jenifer Smith and Dr. Luke Short from DFS. So introducing Kenan first. Kenan Zamore is a senior research epidemiologist with the District of Columbia Department of Health. Working out of the Center for Policy Planning and Evaluation, he is tasked with applying public health surveillance techniques to non-traditional public health problems, most notably violence prevention and substance use disorders. Mr. Zamore primarily works to facilitate the effective dissemination of timely and reliable surveillance data to inform public policy and intervention efforts, and to attack barriers to the routine exchange of vital data. He holds degrees from Stanford University and Tulane University School of Public Health, and he has over a decade of public health experience as an epidemiologist. Dr. Jenifer Smith is next. She was appointed as the Director of the Department of Forensic Services in July 2015. She's a retired Federal Bureau of Investigations agent, having served for 23 years, and was formerly a faculty member at Penn State University from 2010 to 2015. Dr. Smith's goals for DFS include strengthening communication and collaboration between DFS and key agencies while maintaining scientific integrity and independence, emphasizing strong management and fiscal responsibility, and conducting and delivering the highest quality testing and results. She holds a Bachelor of Science in Biochemistry from Penn State University, a PhD in Physiological Chemistry from Ohio State University, and a postdoctorate from Harvard University. And then finally, Dr. Luke Chandler Short is the Chemistry Section Chief at the DC Public Health Laboratory of the Department of Forensic Sciences. In this capacity, Dr. Short founded and manages the Forensic Chemistry Unit, testing evidence for controlled substances, the Clinical Toxicology Unit, testing for drug metabolites and other toxic chemicals, and the Mobile Testing Unit, which is a deployable rapid testing facility for COVID-19. Dr. Short is a technical expert for district legislative efforts on controlled substances, toxicology, and supports outreach to law enforcement and public health agencies. So we will begin with DC Health. So Mr. Zamore, I will pass it over to you, and thank you so much. I look forward to the presentations.
All right, good afternoon, everyone. Can you hear me okay?
Yes, I can hear you.
Okay, so my name is Kenan Zamore. I'm an epidemiologist here with DC Health, and for the last few years, I've primarily been doing injury surveillance, so a lot of violence and poisonings, which overdoses would fall under. So really, we have a three-legged strategy when it comes to looking at the opioid crisis. We look at the fatal overdose surveillance data from the medical examiner, which includes a lot of circumstances about the deaths, toxicology as well. And we have non-fatal overdose surveillance, which we would argue is very important since by the time someone gets to the medical examiner, it's too late. So this is really interesting and useful for prevention efforts, and I think it could make the biggest change. Then we have our surveillance of the actual drug supply, which Dr. Short and Dr. Smith take care of, and they'll paint a very interesting picture for you afterwards. Dissemination is a big piece of our strategy as well. We collect a lot of data, but we also share a lot of data. And we have a multi-agency work group we share this data with. Our goal primarily is to paint an accurate picture of the typical opioid user in DC, but also to detect overdose clusters and respond to them as well. So really the scope of the issue, we started tracking this in about 2014. We had 83 deaths. Then by 2017, we had 279. Last year, we had 278. And this year, we're probably on course to go close to 400. There's been a lot of talk about COVID perhaps enhancing people's risk of death or overdosing. And the numbers we see do seem to confirm that. But we're actually in the process of doing more research to see if we can validate it. So we're doing more naloxone administration than ever. Deaths have doubled, almost tripled in that period. And what we're seeing now is that over 80% of our drug poisoning deaths are related to opioids. So DC versus the rest of the country, we have a very different core group of users, which we found out pretty early. Our average opioid addict is actually 54 years old compared to about 34 or 35 for the rest of the country. There's less racial diversity in terms of the users. It's overwhelmingly African American, and we have people with a very long history of use, 20 plus years. We find a lot of concentration in the eastern side of the city. So wards 5, 7, and 8 are gonna amount for over half of our overdose victims. This is just some stats compared to the US population. So what we see here is that close to half of our overdoses are people over 55, which is pretty concerning. We just don't see a lot of younger drug users, which is strange, and it's something that we're very vigilant about. We've started to see a small uptick in our 35 to 44 population, but it's still dramatically smaller than the rest of the country. And if you look at race, we're pretty much almost exactly flipped, 84% Black and compared to only 14% white, which is the opposite situation nationwide. So this is really the bulk of our exchange strategy. We have the emergency response, which hospitals and healthcare facilities would fall under, then the public health response where DC Health would reside, as well as behavioral health, human services, and most importantly, our harm reduction partners, our testing capacity, Dr. Smith, Dr. Short, and the medical examiner as well. And a huge part of this is also the criminal justice system. We've seen that people tend to touch all 4 of these quadrants. So it's very important that we initiate effective data sharing across all of these areas. So we really just try to build a big work group. So we include public health, public safety, criminal justice, healthcare providers, and private partners as well, and try our best to remove barriers to sharing data. This is actually very sensitive information when it comes to mental health and PHI. So, I mean, there's usually a lot of safeguards in there that have been a difficulty in the past. We use a lot of large data sets. We have EMS data, we have billing and discharge data, we have syndromic surveillance. So the more information we get, I mean, the more accurate the projections we can make. Our goal is to really prevent death. I mean, the only barrier to getting into treatment is being alive. So it's very important that we share information pretty quickly to people who can make a change. And again, to drive targeted efforts and interventions to push people into treatment. So one of the big tools we used is our syndromic surveillance system. It's called Essence. Originally, it was set up to track bioterrorism and possible exposures after 9/11. But we found, since we have the chief complaint and date of birth and the discharge diagnosis codes, we've been able to use it to track overdoses. So we have 4 queries that we use. We have acute opioid poisoning, which is the exact discharge diagnosis. Then we have suspected acute opioid poisoning, which includes a piece of the chief complaint as well. We also have non-acute opioid problem, which is someone with a history of opioid abuse who's presenting to the ER with an unrelated complaint. Then we have suspected overdose, which is really our all drug query. So that's going to be a lot of the PCPs and the cocaines as well. And keep in mind that our drug or opioid overdoses are really going to be about 1/4 of the total drug-related morbidity burden on the EDs. So we track this daily, and when it's red, we issue alerts. Yellows are warnings, so we would look into it. But as you can see, we average probably between 4 or 6 overdoses a day. But these are just people who are transported to the hospital, so you'll see the numbers are actually higher once we start looking at fire and EMS data. And as far as the non-acute opioid problem, keep in mind, since a lot of our drug users are much older, in their 50s, we're seeing a lot of presentations, with uncontrolled hypertension, uncontrolled diabetes. This is actually a fairly sick population. So just looking here, we see that we've had a pretty tremendous rise. We got to 170 in July. We're back down now. As of yesterday, we only had 86. So I think the curve is flattening, so to speak. But I mean, there's been a dramatic increase since the start of the year and historically as well. So We were pretty low for the last couple of years, and then it's been pretty crazy this year. So our average user is about 53, 54. The gender ratio is pretty skewed. About 70% are male. 2/3 of them are going to live in wards 5, 7, and 8. We don't have too many non-residents, but we do have people from Maryland and Virginia. It's just the nature of our metropolitan area coming in and overdosing in the city. And again, largely African-American, over 80%. So firing EMS data is actually the most useful data set that we have. We're a pretty unique area in that we can have a firefighter or an EMS provider anywhere in the city within 4 minutes. So most of our reversals are successful. We have the XY coordinates and the actual location of the overdose, which is very useful when we're looking at clusters. And we also have information about the patient, their date of birth, even their insurance information, and their address that we can use for interventions. We can look at repeat overdoses over a certain amount of time. One thing we try to look at is how many overdoses someone has had in the last 90 days. And since we get the data pretty quick, we can use an outbreak model and really respond to it. But the biggest issue is we're in a situation where about 32% of our people who overdose decline transport. And I know we have the induction programs in the hospitals, so we try to push people to go to the hospital. But if we only counted the hospital data, we'd be missing about 1/3 of the people who overdose. So these are the encounters here. As you can see, again, starting in January, we had a pretty big rise up to July, and we're slowly going back down. But as of now, we're having about at least 200 overdoses a month, which is over 6 per day. So really linking to prevention, we want to detect and we want to warn of unusual patterns, and we want to feed data to our partners like behavioral health and harm reduction. One thing we developed was ODMAP, which we use with the High Intensity Drug Trafficking Agency. So we can send de-identified data on overdoses within about 15 to 20 minutes of the patient care record being closed. So you'd be able to see all the overdoses in the city, and also get spike alerts when there's an unusual number of overdoses. Currently that number is 8. So if there's 8 overdoses in a 24-hour period, that would send out an email, and it would keep sending until the running total went down. This is something you can all sign up for. All you have to do is email me and I can add you to the list. So I'll show you what it looks like. This is what it looks like. Each dot represents an, give me a second. So each dot would represent an overdose. We tier it by how many doses of naloxone. So the purple dots would be multiple doses of naloxone. So we kind of use that as a surrogate for severity of the overdose. And again, this is a tool we encourage people to use. Feel free to contact me and I'll add you to the list. This is internally what we do. So we look at the neighborhood level. And as you can see, the eastern part of the city, the Deanwood area right here, we have a lot of overdoses. Trinidad and Ward 5, we have a ton. The Shaw Corridor right here, we usually have a lot as well. And then Ward 7 and Ward 8. So the main information we share is name, date of birth, and address. Internally, of course, that's just not information we can share with everyone. Where the overdose happened, how many overdoses in the last 90 days, whether they went to an induction facility or not. Sadly, we can't really get much data on treatment history due to privacy regulations. That's something that we're working on. And hopefully we can get patients to opt in to share more data. It's something that's been discussed. So we're piloting this with treatment intake and some MAT programs where people would give permission in advance for us to share their data. As far as prevention, DC Health is now involved. We have 8 rapid peer responders. Behavioral Health has a lot more resources than we do. They have a mobile outreach team, providers, crisis responders. Department of Human Services as well is very involved, since a lot of the people who overdose are consuming their services. And we have FEMS as well. Even in addition to reversing overdoses, they can also leave naloxone behind. So we've basically been flooding areas with naloxone. And we work with the harm reduction and syringe exchange services just to share information and to get qualitative information back from them on the nature of drug use in the city. So we have a response framework when we have a spike. Basically, that email comes out, like I said, and also, so DBH, DHS, DC Health, harm reduction, FEMS and MPD, we all have a regular call. We meet once a week, but usually when there's a spike, we convene fairly quickly and we decide who's going to deploy resources, and we track it until the situation is resolved. We also, working with our harm reduction partners, HIPS and Family Medical, we can send out messages to their social media when there's a spike, which we found pretty useful. They can reach a variety of people that we would not necessarily reach effectively. So using EMS data, we can view overdoses as an outbreak. We can flood resources in there to respond to a crisis. And we really hope to link people to screening, treatment, and support services. And it can also be used to decide how to deploy our resources. If we look systematically where overdoses are happening, it can help our partners allocate their resources. But we also have to be careful in how we share this information, not to stigmatize neighborhoods. We really try to take a harm reduction approach and basically just try to tell people why they need naloxone and where to find it is the main focus of DC Health. Other data sources we use are the prescription drug monitoring program. We do not have a big issue with prescription drugs. I mean, it's something we monitor for, but compared to the rest of the country, it's very minimal. And most of the people who die have not had a prescription in over 10 years. We also have the state unintentional drug overdose reporting system, where we look at a variety of information about our decedents. We look at their history of drug use, the circumstances, whether someone tried to revive them, whether there was a FEMS contact, their criminal history, their history and treatment. And it really informs the Opioid Fatality Review Board, which reviews a couple cases in depth every year. There's also treatment and MAT data and arrest data that we take advantage of. So that's about it. I will stop sharing and I'll pass on to Dr. Smith and Dr. Short.
Thank you very much, Kenan. This is Dr. Jenifer Smith. I'm going to start our presentation. This is a combo presentation from the Department of Forensic Sciences. I want to thank the organizers for inviting us to this meeting. This incredible, it allows us to share information we've been gathering here at the Department of Forensic Sciences. We're going to go through pretty much and focus on our drug surveillance program. So I'll give you a brief sort of history on DFS and the drug surveillance program. And then Dr. Short will come in with actually the sort of nuts and bolts of what we are finding through the casework that we are doing, the monitoring that we are doing with syringes, some information on drug toxicology, overdose monitoring that we're working with OCME, and then some important drug legislation, because at the end of the day, you know, we have data that actually supports many different efforts in the city. So that's kind of the way we look at ourselves here at the Department of Forensic Science. We sort of do the science, we provide data and information, and then many customers can use this data in a variety of ways. So if I could have the next slide. So you may not even know this building exists. We are actually in the southwest portion of the district. We're down at 401 East Street Southwest. There is this gorgeous new building, relatively new. It was opened in 2011, 2012, and it houses two different agencies. We call ourselves the Consolidated Forensic Laboratory Building because we house both the Department of Forensic Sciences as well as the Chief Medical Examiner's Office. So the residents and citizens of DC, we obtained tax dollars and we were able to build this gorgeous building, and it houses a lot of laboratories, a lot of scientific equipment, and within that we do and serve the citizens by basically working different types of cases or looking at different types of evidence that is brought to us. That is our main role at the Department of Forensic Sciences. Next slide, please. So if you take yourself back to 2015, if we can, the pandemic has maybe changed all of our perspectives, but if you go back to the summer of 2015, the city was actually facing an increase in synthetic drug use that include synthetic cannabinoids, also known as K2. And there was really quite an uptick in the use of these drugs, which caused both the city council as well as the mayor to get together and pull emergency legislation together to try to combat this. And at the same time, I was actually coming to the Department of Forensic Sciences as its director. And part of that was due to some problems that the laboratory had had with DNA testing. And it was ironic that on the day that the mayor came to announce my appointment, because she was in the middle of this other epidemic in a sense that was happening, she asked me, she goes, "What are we doing about the drugs?" And I told her at the time, we did not have the capability to actually test for drugs within this gorgeous new laboratory. That in fact, most of the drugs for illegal narcotics, any of that drug testing was being done by the DEA. So it was interesting because it suddenly kind of put to the front of my brain that if we had the space, and which we did, now we needed to have that capability so that we could better serve the city. So if I could have the next slide, I'll kind of show you what I'm talking about. If you look at this slide, this is information taken from sort of the 2017 time period. So this was before DFS had the capability to do testing for ourselves. Those very tall blue bars represent the amount of samples, cases that were brought to DEA, or the amount of drugs that were collected for different law enforcement purposes. The gold bar next to it represents how much of that was actually tested. Because at the time, though there may have been drugs taken or seized through different law enforcement actions, if those cases did not go forward into court, the DEA would not have the opportunity to test that. And that was just mainly a bandwidth issue. They can only work so many cases. So I look at that and go, well, there's a lot of material there that isn't being tested. And therein lies the problem, because if we had all been able to test all of the samples of potential heroin that was coming in or other substances, we might have been able to see that fentanyl was creeping into our drug supply. So in looking at this, what we think about with this program is, though we are here to support law enforcement and investigations, we're actually also here to support public health decisions. So this was our challenge. How do we take a look at all the drugs potentially that are being collected off the streets in order not just to potentially prosecute a case or exonerate an individual, but what is in our drug supply? And we felt like if we could bring this capability in, we would be better poised to do that. So if we can have the next slide. I don't want to necessarily drag you through the organizational structure of the department, but I think it hits on this point that we have 3 divisions that are the functional divisions. We have our forensic science laboratory. That's where you'll find DNA testing, latent fingerprint testing, firearms testing. We have our crime scene sciences group. They're the folks that go out behind the yellow tape and collect all the evidence. And then we also have the public health laboratory. That makes us very unusual. We are an independent agency that typically has, if you hear forensics, you think you only support law enforcement, but here at the Department of Forensic Sciences, because the public health lab division is here, we also do all kinds of testing. We support rabies testing, arbovirus testing, of course, COVID-19 testing for that. But this is where we decided to put our forensic chemistry testing. So the capability you're going to hear about today that is led by Dr. Luke Short is actually led out of our public health laboratory, because that has allowed us to have a broader perspective on how we're going to use this data even though many of the samples you're going to hear about that we have collected have been collected, most of them through some kind of law enforcement action, we in fact are now analyzing them to support both surveillance as well as anything we might be able to do to give information for a case. So the forensic chemistry group actually is now housed within the public health lab. The reason we did that was I already had a small team of chemists that were well trained and well qualified. I just needed to get them some space, some equipment, and some protocols and some funding to support these efforts. So what you're going to see today is sort of a result of those efforts. And if I could have the next slide. One of the programs that DFS was fortunate to get involved in very early on was the mayor's strategic initiative to basically reduce deaths associated with opioid use. Live Long DC, and I'm sure many of you have heard of this strategic initiative. So there is actually a specific goal, goal 7, which says part of this is to enhance surveillance program and data collection efforts in order to determine and characterize status of the regional supply of illegal drugs to ensure availability of sufficient data. And that is where DFS sits. That is exactly how we were able to begin to establish this surveillance program. So it involved us securing funding, which we've been able to do working with the Department of Health, and Kenan actually helped us find funding to support this program. And it allows us to participate in all these interagency exchanges of information. It asks us to provide monthly updates on this data, and of course, release this information. And one thing we are also eager to do is start to push this information out to as many groups as possible, because all different types of groups will take this data and use it in different ways. So the next speaker is Dr. Luke Short, and if I pull up the next slide, he is actually going to take it from here and talk to you all about the surveillance program and some of the data that is coming from that. And it gives me an opportunity to give a kudos to Dr. Short, because if you think back to 2015, 2016, this program didn't exist, nor did all the accoutrements that go with it, the testing protocols and things like that. So I'm proud to turn the presentation over to Dr. Short so he can take it from here. Thank you.
Hello. I don't see myself on the video there. Can you hear me?
We can hear you.
Excellent. Good afternoon, everyone. I'm Dr. Luke Short from the Department of Forensic Sciences Public Health Lab. And what I'd like to talk about is sort of how we've integrated chemistry into looking at various aspects of how opioids have sort of impacted the district. And we start that in looking at sort of a circular model that you see on the slide before you. And the first part of it actually was the most recently developed, but is integral in understanding the source of the opioids in the district. And so these are things such as exhibits that are submitted by various law enforcement entities, so we get data both from the actual casework as well as surveillance, where we have a material that we test. Whether or not it goes to court, we still test it. Like the opioids and the heroin, which fortunately we've been able to scale up to 100% of all exhibits that are seized in the district for heroin and opioids. We're able to test for some time now. And that falls under the forensic chemistry unit, also accredited to ISO 17025 reporting. And regardless of whether it's surveillance or not, that's all in the same standard. Recently, we've been able to also reach out to various groups through DC Health, looking at the needle exchange or the syringe exchange program. And this has been a missing component for quite some time, because it's often a more challenging aspect analytically, both for safety reasons, as well as looking at trace levels of drugs, as opposed to what we used to look at in the supply, where we'd have an abundant amount to test. And this has given us a very important slice of the picture to look at what's actually being consumed in the district, not just what's being seized or sold. Finally, we have another section here, actually at the bottom of this little wheel here, looking at the toxicology. And one of the things we did with assistance from our LRNC, which is in the same chemistry section, is to develop the CDC's LRNC panel for fentanyl analogs. It includes a little over 22, 23 fentanyl analogs and their metabolites. And we've been able to screen specimens collected as part of a reference study from the Department of Behavioral Health, their opioid treatment program, to sort of see what's in the population of users, to sort of take a deep dive into the fentanyl analogs within that group. And also, of course, looking on the left side, overdose syringes. We've worked very closely with the medical examiner's office for several years now, supporting their medical legal death investigations, as well as syringes picked up on scene, to help provide both intelligence for them, as well as to gain a picture of what syringes, or what mixtures in syringes actually are the most lethal. And finally, over the last several years, we've worked intimately with the Office of the Attorney General Office to act as the subject matter expertise and help sort of develop this legislation of synthetic drugs in the district, to include the emerging drugs, and be able to classify them to support law enforcement and understanding and sort of wrapping their brains around how they're classified. So next slide, please. So here we see a very interesting shift where, since we came on in 2018, where we took over the reins from DEA in doing drug testing, and we're able to get all these statistics and really gain an understanding of what's out there. We've seen a huge shift in the district from what was mostly heroin with slight levels of fentanyl to what is mostly now fentanyl with every once in a while you finding heroin. It was a dramatic shift that happened over the last couple of years, and it's also been very interesting as far as the dynamics of the analogs. But here you see it's not always the same. In some regions of the district, you see more of a shift towards fentanyl, in other regions less. And it's just, when you put on a time scale, it's fascinating to watch it as it goes over time. But this is, of course, very valuable information then to push to outreach communities, as well as various groups, and get Narcan to those areas, because obviously fentanyl is more dangerous, and you'll need to use a lot more Narcan in regions where fentanyl is a lot more prevalent than where it's not prevalent. Next slide, please. So as I mentioned, one fascinating aspect here is the shift in what specific analogs are present. And if you've noticed at the beginning of this, so we were able to go back to the case submissions back to about 2017. So even though we weren't officially accepting cases, the cases were seized from exhibits back in October 2017 here. So we were able to get an idea of what was actually going on back then. You see that there used to be a lot more diversity in analogs, and especially fluoroisobutyryl fentanyl, the FIBF there was a lot more common. And over time, various chemicals waxed and waned as time progressed. But what's been very interesting recently is that there's been a greater and greater shift away from analogs and towards fentanyl. And many reasons behind this. I mean, one of them is that they're because of the way that the laws are written in DC now as a result of the Safe DC Act, we're able to sort of classify all of them as illicit substances of synthetic opioids, but also it's very likely that it's just easier to produce bulk fentanyl. In any case, we do see a dramatic decrease in the unusual fentanyl analogs and an increase in just straight fentanyl. Next slide, please. So we looked at also the what is out there in the syringes as well as pills. And so what you'll see here is the left-hand side, you'll see a distribution of where we are right now with heroin, adulterated heroin, and fentanyl and analogs, just straight fentanyl and fentanyl analogs. And what's interesting about this is that there is a little bit of distribution. It's not entirely one or the other, but you do have slight localities where you tend to have one type of distribution versus the other. What we did also, though, is a study of what are the prescription drugs. So we did a deep dive into what we thought were oxycodone pills, for instance, and we looked at prescription medicines, and we actually started pulling the pills off the streets. We found out that, and this is kind of a startling fact for us, Last year, it was about 1% of the oxycodone pills that were being sold illicitly. That is not from a prescription, from a pharmacist, but just off the street. About 1% of them last year were actually counterfeit. They were really fentanyl. And what happened over the last year is this now has gone up where 1 out of every 2 pills basically is not oxycodone at all. It's actually a fentanyl pill pressed to look like oxycodone, but it's actually fentanyl. And that was a very alarming trend that we didn't see. And we wouldn't have seen had we not decided to broaden our net of looking not just after powders and syringes, but to include prescription medicines. We hadn't known that prescription medicines were that faked. And we wouldn't have seen that huge uptick all of a sudden in illicit fentanyl use. Next slide, please. So very recently, and this just took a lot of effort with various organizations to pull together the logistics of this. We were able to get the syringes from various syringe exchange programs now. We get some, I think it's about 40 to 60 syringes every week that we test. And we do washes of them to look at what's out there. And what has been fascinating so far is a couple things. One, it's actually very representative of the illicit supply that we're seizing and testing. So if you look at what comes in from law enforcement, as well as what comes in from the streets on submissions, it all ends up being about the same of what we're actually seeing in the syringes. Now, I should note that this has been excluded from other drug types, and we're just looking at powders at this point. Or things that could be easily turned into powders. So that is very heartening in that if you only look at one of these data streams, they actually agree with each other. So it's very supporting in that. A couple other interesting things. Excuse me. Get some water real quick. A couple other interesting things is that we've seen recently a very large intake of methamphetamine or meth, and that's actually gone much higher in OCME's samples that were submitted to us, as well as an interesting statistic that xylazine accounts for about 20% of syringes tested. So although we say we see fentanyl, along with it, you have about 20% of those syringes are actually xylazine is on board too, and that's been also a recent trend upwards. Next slide, please. So finally on this, we see that we have another interesting study that we did with DBH. We had the opportunity to do a specimen test of about 147 of them as part of our method validation for a fentanyl panel that we were bringing on board to get reference values for specimens tested as part of their opioid treatment program. So at first we were just looking for methadone and EDP, which is part of the methadone treatment, and we're starting to get an idea of what's out there and what levels should we expect. But part of this was also to do the deep dive of the fentanyl analog panel. And that was the interesting thing for us, is that within the opioid treatment community, if you take all the specimens, so not knowing, since they've been de-identified, not knowing whether someone has just started or is concluding the program, if you take a conglomerate of those and look at them, you do get fentanyl in those specimens. And if I can see the next slide real quick. What we see here, on the bottom is what the LRNC, so the CDC LRNC panel looks at, and highlighted red are the items, the metabolites, as well as the parent drugs that we see in the specimens, what we find in the panel. And on the top side are the actual sort of average values of what we saw. And it's interesting to note that it is about almost 60% had some metabolite of fentanyl present. And so this is still, it's of the user community, of those that are seeking help. But it's important to note that individuals on this program, as we saw with the opioids, they may very well not even know they're taking it and have fentanyl in their system. Because if you take an illicit oxycodone pill, for instance, if you're dependent upon it, there is a chance, fairly good chance, that you're actually taking fentanyl. And so that'll show up on the screen. Next slide, please. So part of the interesting lessons learned from looking at syringes from the Office of the Chief Medical Examiner is that there's a huge shift towards more fentanyl. Obviously, that's more deadly. And so of those syringes, we see a much higher percentage are actually containing fentanyl. And that was sort of understood that you would see that in the shift in statistics for medical examiners' submissions, but also important to note. Next slide, please. And finally, what was important to note on this is that we've been working very closely when we take these drugs and we identify them to confirm that they still fall under legislation. And so as anything new comes up, we check it against this to make sure that we have an adequate law to look after this if someone's distributing it, to classify it and be able to properly go after it. Final slide, please. Well, actually, click once more. I think there's some things in here. If we could just bring up all those for the brevity of time. Thank you. So what was interesting to note is we cycle through this wheel here. We see that roughly 74% of the heroin that we looked at has fentanyl. And when we look at the syringes, we see that the syringes of the users also matches this statistic. It's a very similar number of fentanyl and heroin. When we go down to the toxicology of the user community seeking help, we see roughly 60% still have fentanyl metabolites in their system. And on the syringes, we see that we have a much higher proportion of those syringes actually contain fentanyl. So we see that there is some link there with the fatality. And finally, in the legislation, we currently have 3 defined categories of fentanyl and metabolites. So fentanyl, carboxymethylfentanyl, which includes carfentanil, and the benzamides, which fall under the Safety C law. So with that, I think that's it. Last slide, please. I thank you, and I will pass the presentation over.
Make sure you unmute yourself, Elizabeth.
Always have one. Just thank you so much. I think to all of our presenters, seeing those data together triangulated is really interesting. We do have one question. Attendee asked, we tend to hear that there are more non-minorities overdosing in suburban areas. I now see that the case is opposite in DC. Do more non-minorities overdose in the suburban areas? No, Kenan, that might be one.
Yeah, thank you. Great question. So I would say yes, and I think the issue there is new users and younger users. A lot of our users started using in the 70s and 80s when the demographics of DC were very different from what it is now. I think people who were initiating use recently tend to be different demographically. And I mean, just also just the demographics of Montgomery County compared to DC.
Thank you. If anyone else has questions, feel free to put them in the Q&A feature at the bottom of your screen. We're happy to take those. I guess just personally, I think that statistic that 47% you're seeing 47%, is it of, what's the denominator there, with fentanyl in oxycodone pills? That's striking, and certainly something I think of interest to the healthcare community. I guess to Dr. Smith and Dr. Short, you talked about the ways that you've expanded your kind of the supply that you look into using the syringe exchanges and a partnership with DBH. In a perfect world, what other areas of supply would you like to look at to better get us even a closer sense of what the drugs in DC are?
I mean, I know that this is something that I think we need to think about. If you look at drug use as a pure public health issue, then to be honest with you, we would like to know what every person is taking. Because if you go out and if you think about it from a simple, when I buy drugs from a pharmacy, the quality assurance is very good. I know what I'm getting. What our folks are facing out there is they're really taking these drugs. They're illegal. They may be, they need them and they don't know what they're getting in them. So from that perspective, we don't often know when somebody shows up at a hospital what they took. And we understand that's because they either consumed it all, they're afraid to talk about it. So I think it's important for us to think about this differently, and that we stand as a laboratory, that we're not in judgment of anybody. We want to know what you took so we can help you, so that we can understand, so we can put warnings out there. Because we actually don't feel like the folks who are selling these drugs probably care as much what's in them. And that's the big difference. So I think if we change our perspective to that, then we want to test anything, any sources. We really want to get at this to help people know what they're up against, because it's hard enough to have to be in a situation where you need some type of drug, but to be compounded by the fact you really don't know that they're safe. And I think that's the discussion we love being in as a part of seeing this from a public health perspective. So if there's folks out there that can help us, how do we get to the supply without necessarily worrying about locking everybody up? And I think that's the message we're really talking about. Like, we will test anything that is brought to us, but right now, most of what's being brought to us is coming from that sort of angle. So we'd like to make this, I know it sounds kind of silly, but we actually need to make this supply as safe as possible for people, or help people be informed, better informed. So that's why we enjoy doing these conversations, and then going to different groups of folks who may have ideas on how we could get a broader sampling out there.
Yeah, absolutely. I think that's an interesting perspective. And if anyone on the line has any ideas or connections for that, please do send us an email, and we will make sure that we connect you with the DFS team for next steps. We do have another question. How much of the shift from heroin to fentanyl is the cost of drug for users? So how much of that is due to a lower cost?
Oh, I believe I can answer that. So I texted back the answer to this, and essentially we have some studies on this. We haven't released any studies on this, but we do track sort of cursory the value, and it is much, much cheaper. We have done a couple models of showing that this might be one of the driving demands, but as I mentioned, since this goes more into the law enforcement's lane, we've not published anything on that. But I would say that fentanyl is a lot cheaper to produce, and I think that could very well be one of the reasons.
Thank you. Another question that came in: are you aware of the public or more affected communities receiving the message that the drugs are not safe? Is there evidence that messaging to affected communities changes behavior? So are these messages reaching the people?
So DC Health and DBH have very aggressive communication campaigns that are actually very targeted to that demographic by location as well. But I think the issue, as you all know, is the hardest thing to change is human behavior. I mean, we still have people smoking cigarettes, we still have people not wearing their seatbelts. And coupled with the fact that these are people who have been using for a very long time with multiple treatment episodes, are just very, very tough to deal with. So all we can do is try, and our efforts are noble, but it's really hard to say. And we try to really kick it into gear when we know that there's actual danger. But what we really speculate is that we don't think use has increased so much, but like Dr. Short and Dr. Smith pointed out, it's just the supply has gotten so much more dangerous. And people who've used successfully for decades are now dying with one dose, when really they could handle that in the past.
And I'll just add that we are eager to share this information with any communities that you think we need to. Sometimes it's been interesting, the reaction we've gotten from some of the peers that we have worked with. They are fascinated by the data, and we do spend time. So if there are opportunities such as this one, or some place where I can either send Dr. Short, or we can get on a phone call and share that, to go along with the aggressive campaign that is going on. But it's an interesting city in that we're very small, and there are a lot of people working on this effort. And if they want to spend time talking to us about our data, we're happy to share it if that sort of would be helpful. So that's one reason we wanted to partner on this call, was so you knew that we existed. We are available to do these, and we will share this data, and we will even shape the shape the presentation in such a way to answer specific questions of groups. so that we can, help people understand the risks that they are facing.
Yeah, but I think a lot of it just boils down to perception of risk, and there has actually been a lot of misinformation about naloxone as well, and its utility or any danger there. So I mean, I think the big thing that we were missing as far as a surveillance strategy is kind of qualitative information coming back from drug users, since it's really such a sensitive topic to discuss and that it's illegal. But that's definitely a piece of the surveillance that's missing.
If I could also add real quick, the thing that's frustrated me a lot is that still within the community at large, there is a great misperception that if someone takes a narcotic, they pass out, that automatically they assume it's fentanyl or something. And fortunately, we began this whole process looking at spice and the spice issues back in 2015. And that's often the case. And so many times you still have people who are they're smoking something like spice or marijuana, they pass out, they assume it's fentanyl. We have yet to see in the district spice laced with fentanyl. So I mean, it's probably just a very strong type of spice that has knocked someone out. So I think education to the response community on what are the signs and symptoms of spice versus fentanyl, because there will be different sort of directions that you take after that, as well as education of the public that there is a difference between marijuana and what used to be called fake marijuana with the spice, which is just, it goes after the same receptor, but it's a very different chemical, and then fentanyl. So education is very key here.
I think that also highlights the importance for the work that DFS is doing in terms of the surveillance of the drug supply. We've been very vigilant looking at nationwide trends. I know Dr. Short and Dr. Smith are plugged in nationally, but look at in New York where you had fentanyl in the cocaine supply. Someone ingesting cocaine is not going to have naloxone in their house. So that's danger right there. So it's very important that we can detect things like that and push that information out to users and providers as well as quickly as possible.
So one last question, I think we have time for one more. If people, either at an organization, like you had mentioned HIPS or other CBOs, or hospitals wanted to submit samples for testing, is there a process for them to do that?
Yes, we'd be happy to work with you to create that process. So whoever that person would be would reach out to me at the Department of Forensic Sciences. You can, my email's there, my phone numbers are available at our web page, and then we would work with you to see how we could do that. So as an independent agency, we can receive samples, not just because they're coming through law enforcement. So we would want to probably talk to Department of Health or something like that. But yeah, we'd be interested to work with you to figure out how to do that.
Excellent. Well, thank you. Thank you, Dr. Smith, Dr. Short, Kenan, and all of our attendees as well. I thought that was a great conversation and really helpful information. So appreciate your time and expertise today.
Thank you.
Thank you.
Alrighty, so with that,